Morning, everyone. All right, let's start. So today I'm going to discuss about sleep apnea in children. So I'm a pulmonologist, but this is a sleep topic. So probably somebody is wondering why. But pulmonology and pediatric sleep medicine is almost like siblings or twins, actually. So most of these children with sleep problems are managed by pediatric pulmonologist. And I have a special interest in pediatric sleep medicine in terms of research and advocacy. So I thought I will do this for today. All right. I have no disclosures, but my doors are open. Yeah. So the objective for today is discuss the epidemiology and clinical presentation of sleep apnea in children. This systemic nature of the disease is no more considered as a local disease. It's a systemic inflammatory disease. Lists a complication of untreated OSA and spread the awareness that early identification and management is crucial for these children, and update some management options. But mainly I want to focus on the complications of unidentified and untreated sleep apnea in children. And also talk about the screening and identification and early referral for these children for appropriate management. So the slogan from my side for these children today is to not ignore the snore. Yep. All right. So we all wish that we can have a good night's sleep. How many of you slept 8 hours last night? Not me. Anybody? 8 hours? Good. So we all adults, we all supposed to sleep 8 hours every night. Period. Ideally. Okay. I'll tell you why that is required. So sleep is a very important vital function, right? And sleep is related to memory and learning. Lack of adequate sleep can cause problems with memory, learning, cognition, performance, everything. Children, adults, everybody. So sleep is very, very important. Okay. So there are some studies showing that pediatric children with sleep problems, if not treated adequately, is associated with the special education, need of special education at the age of 8. So it's important to get your Z's. So sleep is basically a biological cleaning service. It actually cleans the brain. It cleans a lot of toxic waste products from the brain. There is about 60% of increase in the interstitial space during a good 8 hours of sleep during night, and that is required for clearing waste products and toxic waste products, including many products, including beta amyloid clearance from the brain. So sleep is almost like a taking out trash business, and we all should have it. This is actually came recently in Science, and this is a very important article, and it really signifies the importance of getting a good sleep and why we need to have a good sleep. So adults, all of us need to sleep for at least 8 hours, and teenagers, adolescents, at least 9 hours, and it increases in small children. So 8 hours of sleep. So basically, get your 8s. It's important. So let's go to obstructive sleep apnea directly. I think we had a grand rounds on sleep, general sleep and importance of sleep and all those things a couple of months ago. So let's talk about specifically on obstructive sleep apnea in children today. So it's defined as prolonged partial upper airway obstruction or intermittent complete obstruction that disrupts the sleep or causing interrupted sleep and also affecting gas exchange, affecting oxygenation and ventilation, causing hypoxemia and hypercarbia. That is obstructive sleep apnea. And it's a spectrum. Sleep disorders, breathing, it's a spectrum starting from snoring, primary snoring or habitual snoring, to upper airway resistance syndrome, nocturnal hypoventilation, and the end of the spectrum is obstructive sleep apnea, which is the worst. So habitual snoring is about 7%, prevalence is about 7% in children, and prevalence of obstructive sleep apnea is 3 to 5%, and it is more in some special population like syndromic patients and achondroplasia and Prader-Willi syndrome. So this was one of our research projects which I was part in the Washington DC area, involving children from DC, Maryland, and Virginia, about 400 children. We were studying about the prevalence and the epidemiology of these children, and one of the big problems what we saw is delay in diagnosis. So this was presented in International Sleep Meeting last year in Baltimore. So many of these children, above 7 years, they were diagnosed at about 2 years. 2 years after onset of symptoms. So there is a significant delay in diagnosis. And these results are similar to many recent publications nationwide. And also small children, they are diagnosed at 1 year after onset of symptoms. This is very, very significant. So they are being with these symptoms for about 2 years in our study. So this is very important. So what are the consequences of not identifying and treating them early? I'm going to talk about those things. This is very significant. So based on this, we made a good advocacy to Academy of Sleep Medicine and Academy of Pediatrics to get some funding to look into these details, and that's the phase 2 of that project, to go to the community and provide us and see why this is happening. And then we assuming it is because of lack of awareness from the family, and also lack of screening from the primary care providers. And an unpublished survey showing that only 50% of primary providers are only screening for sleep symptoms in children and look for these things in children. So we also found that some disparities in diagnosis. In African American children were diagnosed late, delayed compared to Hispanic and Caucasian population. And there are some geographical variations. Inner city children are diagnosed late compared to children with suburban and other wealthier neighborhood. So symptoms, all right, and we all know the primary symptom is snoring, not night symptoms. These are all nighttime symptoms. Snoring is an important symptom, and all the snoring is not sleep apnea, as I said before. And here you can see he's snoring like a champ, right? and see it here, many people are bothered about the snoring. This guy is bothered, he's bothered, and even he's bothered about the snoring. Snoring is important, right? Especially loud snoring. You can snore like a train, you can snore like a truck or whatever. So snoring is the most important symptom, right? And other symptoms you have to ask, especially in children, choking arousals, physically awake, choking or gasping type of breathing, pauses in breathing, especially in small children, infants who's born premature, pauses in breathing. So parents need to look for those pauses in breathing. And sweating and aneurysm, these are some symptoms. Nighttime symptoms of sleep apnea. Ask for these symptoms when they come for your well-child visit. How about daytime symptoms? Excessive daytime sleeping is one of the most important symptom. This is a common scene. I did my residency in Brooklyn, New York, and I use metro train most of the time to go to work, and I see this all the time. And sometimes I fell asleep as well in train as well. But so daytime sleepiness is the most important symptom most important daytime symptom. But not every child with sleep apnea will have daytime sleeping. Especially preschool children will have this, jumping off the wall. About 1/4 of children with obstructive sleep apnea, especially in the preschool age, will have hyperactivity. So hyperactivity is an important symptom of undiagnosed, untreated obstructive sleep apnea. If you see a child with hyperactivity, treating for ADHD, ask for the sleep. And importantly, it can be preventable in the early phase. If you treat them, this can be preventable. You can have a child with a better school performance and cognitive abilities. And also learning disabilities, an important consequence of untreated obstructive sleep apnea. So other daytime symptoms include morning headache and mood swings and alterations in blood pressures and things like that. So this was one of another study. We were looking for the age group and prevalence of obstructive sleep apnea in children, and these are the children, early toddlers and preschoolers and early elementary school kids. These are the children who is affected mostly, and we should focus on those children and capture them. And that is because of, I'm going to tell you next slide, and that's because this is the time where they have biggest tonsils and adenoids. The maximum growth of tonsils and adenoids happening this time, and that is the most common cause of obstructive sleep apnea in children. Okay, so this is the time. And other peak is actually in the adolescent age group with children with obesity. So risk factors of obstructive sleep apnea, as I said, tonsil adenoid enlargement, obesity. So these are the two main risk factors. Asthma, I'm going to tell you later, but asthma is another risk factor. Allergic rhinitis and blocked nose, obstructed nose, acid reflux, and craniofacial abnormalities in neonatology, like Pierre Robin syndrome and other craniofacial abnormalities, craniosinostosis. These are big risk factors for obstructive sleep apnea in children, and prematurity. They can have increased obstructive sleep apnea. And you can see that adeno-tonsillar enlargement is important in preschoolers and early school age group, but obesity is a big risk factor in adolescents. Smoke exposure is identified to have associated with obstructive sleep apnea in children. All right, so what is wrong with these kids, students, residents? Sorry? What do they have in common? Open mouth, right? Long face, open mouth, mouth breathing. What is wrong? This is typical adenoid facies. So you should catch these children. So when you're coming to your visit, your well visit or even sick visit, you should catch these children. So this is called typical adenoid facies, and ask for their night symptoms. Just spend 2 minutes asking for them. They will tell you. The parents are going to tell you, oh yeah, he's snoring like a champ. Yes. So this is the biggest risk factor. Identify these children. This is called adenoid facies. So they're probably having big adenoids, and they have open mouth breathing and upturned nasal tips and thick nasal discharge, nasal congestion. They are chronic mouth breathers because their nose is blocked all the time. So they are at high risk for obstructive sleep apnea. And so big tonsils and big adenoids are biggest risk factors in preschool children for obstructive sleep apnea. And also in teenagers and adults, obesity is the biggest risk factor for obstructive sleep apnea. So basically, the big tonsils, adenoids, and also muscle tone, low muscle tone, hypotonia, any problems causing hypotonia, Down syndrome, syndromic patients, or neuromuscular disease, Duchenne muscular dystrophy, spinal muscular atrophy, anything causing muscle hypotonia, and also small airway size. Some of the studies done in premature babies, MRI studies showing that they have very small airways size. So these are all interplay to cause obstructive sleep apnea in children. So X-ray can show, lateral X-ray can show big adenoids and tonsils. So special population, as I mentioned, Down syndrome, they have special facial characteristics like mandibular hypoplasia, midfacial hypoplasia, and glossoptopsis, causing, putting them at higher risk for having obstructive sleep apnea. So the classification is type 1, type 2 mainly, and there is a type 3. Type 1 is basically preschool children with adenotonsillar hypertrophy. Type 2 is obese children, and there is a type 3 which is craniofacial abnormalities and neuromuscular disorders. So sleep, interrupted sleep and obstruction, hypoxemia causes a lot of stress hormone release, imbalance in stress hormone during our sleep. So interruptions in sleep, abnormal gas exchange, cyclic desaturations, hypercapnia, occlusion of the upper airway and fluctuations in intrathoracic pressures, and brain arousals. You can be physically awake or brain is awake. All this can cause a lot of sympathetic nervous system activation and stress hormone release, which can damage your system and many systems and cause problems in blood pressures and stuff like that. So this is very important. So you should identify and treat them appropriately. So obstructive sleep apnea is no more a local disease. It's not just a mechanical obstruction in the throat. There's a systemic component of that. There's a low-grade systemic inflammation going on with the obstructive sleep apnea. There's a lot of research going on last few years about this, causing cardiovascular, metabolic, and neurobehavioral complications. Most importantly in children, neurobehavioral complications. That is actually immediate. But cardiovascular complication comes a little late probably, but immediately what you need to focus on is on neurobehavioral and cognitive complications. Sleep fragmentation, interrupted sleep is associated with pro-inflammatory activation of pro-inflammatory pathways and neurohormonal changes. And these are some cartoons showing the relation of obesity and obstructive sleep apnea through inflammatory pathways. I'm not going to go through those details. And also cardiovascular morbidity, oxidative stress, cyclic desaturation, and hypoxemia and reoxygenation can cause oxidative stress, and endothelial dysfunction causing cardiovascular morbidity. They can have cardiovascular problems and hypertension in the future. And MRI studies are showing that there is neurological problems and problems in the brain causing cognitive control and stuff like that. And it's well recognized in adults that there is a connection between OSA and metabolic problems. It's well identified. In pediatric studies are still going on, but in post-pubertal adolescents, especially obese, they have association with the metabolic syndrome. And prepubertal children, they have OSA untreated OSA can have problems with the cholesterol metabolism and insulin resistance. So a lot of phenotypical variations, and as I said, it starts with the habitual snoring, going to upper airway resistance syndrome and hypoventilation, and finally obstructive sleep apnea syndrome. And there is an interplay of individual genetic factors and the severity of OSA, hypoxemia, and interruption of sleep at night, and also a lot of environmental influences including nutrition, obesity, and smoking, and physical activity and stuff like that. So it's a complex disease. So this is one of the important take-home slide I want to talk today, the consequences of untreated obstructive sleep apnea. Okay, so in our study we saw that children are lingering with the symptoms for about 2 years. So by that 2 years, some of these consequences can already happen. So pulmonary hypertension, copropulmonale, endothelial dysfunction, insulin resistance, especially with obesity, dyslipidemia, neurocognitive impairment, very important in early preschool and elementary school kids, hyperactivity, attention deficit, and concentration problems and learning difficulties, and impulsivity. And especially the neurocognitive impairment is extremely important, and we are advocating for the committees and associations to focus on this and get funding to do more research on this aspect to help our children. So this is a very early study about 20 years ago by David Gosal. He's a big guy in pediatric sleep medicine research. This study was done in New Orleans actually. So he took about 250 first grade children from a school, a few schools, and so those children were in the lowest 10th percentile of performance, school performance. So low performing students he took, and he screened for obstructive sleep apnea and sleep disordered breathing, and he found that those children, out of those 20% of children had some type of sleep disordered breathing or obstructive sleep apnea. So that is a very important finding, and he followed those children, and he suggested treatment, and many of them had tonsil adenoids, and he suggested treatment for all of them. Half of them underwent surgery, and half of them parents denied, they didn't want the surgery. And who had the treatment, children who had the treatment, in the second grade they had improved improved school performance, but half of them who didn't have this treatment, the grades remained low or decreased actually. So that's a very, very important finding. showing that untreated obstructive sleep apnea can cause decreased school performance and cognition problems like that. So after that, many studies came. Many other studies came after this in adults and children, showing that untreated sleep apnea can cause significant neurocognitive impairment. It's not just in children, adults as well, actually. And the most vulnerable population is small children, less than 2 years, and old age in 60s and 70s. So this is very, very important. This is one of the big take-home I want to tell all of you today. Untreated sleep apnea can cause big problems, which is actually preventable. If you treat them, this is preventable. And in the early stage, hyperactivity, cognition problems, learning disabilities, we can improve. They can improve. So relation between asthma and obstructive sleep apnea. This is our study group back in DC Children's Hospital. We conducted a study in about 350 children, showing the relation between asthma and obstructive sleep apnea. Actually, it's proven that there is a big relation between asthma and obstructive sleep apnea. About 30% of children with OSA can have asthma and vice versa. In our study, we found about 33% of children had asthma, and asthma was the biggest. This is a regression model showing that asthma was the biggest risk factor for obstructive sleep apnea, and adjusted for other factors, other risk factors. And even after adeno-tonsillectomy, those children with asthma required CPAP. Significant amount of those children required CPAP. So asthma and OSA has a big relationship, and it's a bidirectional relationship. Control of one require the control of other, actually. And we should ask always, for children with asthma, we should ask for sleep symptoms, and children with obstructive sleep apnea, we should ask for any asthma symptoms. Control of both is very, very important. And sickle cell disease and OSA has a significant relationship. About 30 to 40% of children with sickle cell disease can have sleep disordered breathing and obstructive sleep apnea. So how to diagnose? So history is important. As I said, nighttime symptoms, daytime symptoms, learning problems, hyperactivity, asthma, all those things. And there are some very useful pediatric sleep questionnaire. One is called PSQ. There's another question what we use in our sleep lab here, actually, sleep clinic. It's called I am sleepy questionnaire. There are 8 questions where you can do. Actually, you all can do it in the pediatric clinic as well, at least once in a year for these children, and focus on these preschools and preschools and early elementary school kids. So 8 questionnaire, and there is scoring system. If the score is 2 or less, it's fine. If it's 3 or more, you probably want to refer the child for a sleep evaluation. So we have a quality improvement project going on actually in the cystic fibrosis population. We are screening them using this questionnaire in pediatrics. And adult, they have another questionnaire, pediatrics and adult, to see the prevalence of sleep problems in CF population. Oximetry studies can be used. Actually, oximetry is pretty good to rule in OSA, but not to rule out. Oximetry normal doesn't rule out obstructive sleep apnea. Here in US, we use a lot of sleep studies, and that's a golden standard, but some other countries, and especially some European countries, they use nocturnal oximetry actually to diagnose sleep apnea. So home videos, not very useful. Home sleep studies being used a lot in adults now. Now insurance is giving a lot of problems. They don't approve institutional sleep study for adults a lot. But children still, they are getting approved in lab sleep polysomnogram, and so polysomnogram is the gold standard for diagnosing obstructive sleep apnea in children. And it's a very comprehensive and very sophisticated study, right? You can see that a lot of leads, EEG leads, and nasal flow, oronasal thermistor, a chin lead, a microphone to record snoring here, a chest lead, an abdomen lead, and a leg lead. This is a very, very comprehensive study to look for many, many vital and biological parameters during the whole night of sleep. This is called hypnogram. This is the whole night of sleep study in one page. Okay, and here this is a polysomnography report comes as it's called hypnogram, one page. This is a very informative to look the overall picture of the whole night sleep, and here you can see what is the stages of sleep. You have REM and non-REM sleep. Non-REM is divided into N1, N2, N3. N3 is the deepest sleep. And these thick black lines are REM sleep. We should have at least 25% of REM sleep during our night. That's very, very important. The one way to know, all of you had REM sleep is the time where you dream and you can remember the dream. So in the morning, if you remember some dreams you had, that means you had a good REM sleep. You are good. So REM sleep is very important. We all should have good REM sleep, at least 25%. So this person had a decent REM sleep, and here is the heart rate and the limb movements, and here is apnea and hypopnea. I'll tell you what is apnea and hypopnea next couple of slides. And here is oxygen desaturation. He had a pretty bad desaturations, and also you can see that his desaturations and apneas are more related to REM. So it's REM related OSA. And here is the CO2. They are measuring the CO2, end-tidal and transcutaneous CO2. And also this was a split study actually. That means they use CPAP for this study. In the initial period they didn't use anything as a baseline study. Then they found that significant apnea, hypopnea, they started using CPAP and they went up with the pressure up and up to control. But you can see that even with the very high CPAP pressures, it's about 15 centimeters. Still there was no much break of the apnea, hypopnea. That means this person has a very significant, severe obstructive sleep apnea. So this is called epoch. One epoch means a screenshot or a screen view of a sleep study, which is about 30 seconds. So they are going to, the technician and the physician is going to look at these epochs actually 30 seconds for about, your sleep studies for about 6 to 8 hours. So every 30 seconds, they're going to look and count events. Okay? This event is called hypopnea. Hypopnea means a reduction in flow through the nose and mouth. And it's about 30% reduction. You can score it as hypopnea. Hypopnea is usually associated with either desaturation or a brain arousal. Here in the upper part is the EEG, limited EEG, and here is the EKG, and these blue lines are the flow. They look at the flow through the nose and mouth, and these purple lines are the abdominal and chest leads. Okay, and the bottom is oxygen saturation. So this is hypopnea, and this is apnea. You can look at the blue lines. This is completely flat, so there is no flow happening here. This is apnea. And look at the chest and abdomen leads. There's almost like a paradoxical breathing. So he's struggling to breathe. This is apnea. This is a very classical example for obstructive sleep apnea. And you can see that here is a lot of runs of obstructive sleep apnea. Look like this patient had a severe obstructive sleep apnea. So based on the hypopnea and apnea, they are going to count all these events, hypopnea and apnea, and then see how many total events, and then how many hours the patient slept for that day, and divide these events by number of hours. So we'll get an index called AHI, or apnea hypopnea index, and that's what we use to diagnose sleep apnea and apnea hypopnea index. And if the index is less than 1, or some others say 1.5. This is for children, okay? It's normal, and up to 5 is called mild obstructive sleep apnea. 5 to 10 is moderate obstructive sleep apnea, and more than 10 is severe obstructive sleep apnea. And also, we take into consideration about the oxygen desaturation. And here, if it's less than 1, it's called just primary snoring or habitual snoring. So Dr. Ghazal and his colleagues came up with the diagnostic criteria, especially to see whom to treat and whom not to treat. The major criteria include the AHI and the desaturation and arousal index, and some symptoms like academic problems and hyperactive disorders, excessive daytime sleepiness, and neurosis, hypertension. These are the major criteria factors. And also minor criteria, there are some lab tonsils, adenoids, some labs of inflammatory markers, cholesterol, fasting insulin, and some other criteria. So what he said is, what he proposed is, if there are 5 major criteria, that's an indication for treatment. Or 3 major or 3 minor criteria, that's also another indication for to send this child for treatment. Moving to management of obstructive sleep apnea. I think I have to stop at 8:35. Probably I have to rush a little bit, but you can stop me if anything is not clear. So management is the primary management is for these children is, as I said, it was biggest risk factor is adenoids and tonsils. The primary management is send the child to ENT doctor for adeno-tonsillectomy. And some of the children also require positive airway pressure CPAP, and some children require BiPAP. Some dental procedure are recommended sometimes, and other surgical options like uvuloplasty. Adjunct therapies include weight loss and positional therapy, and resistant cases and some syndromic cases and craniofacial abnormalities probably require tracheostomy. That's the last resort to bypass the whole thing here. Sorry, this is a busy slide, but moderate and severe obstructive sleep apnea, yes, treat. If more than 5, go ahead and treat. Mild sleep apnea, 1 to 5, plus associated inattention, behavioral problems, learning difficulties, or growth failure, yes, go ahead and treat. Mild sleep apnea with syndrome, Down syndrome, craniofacial abnormalities, neuromuscular disorders, yes, send for evaluation and treatment. Primary snoring, actually, you don't need to, probably not to treat, just to observe them. So primary treatment is adeno-tonsillectomy, and these big tonsils and causing symptoms need to come out, okay? And effect is good, outcome is 75% of these children will get better with adeno-tonsillectomy, but still the 25% with the residual sleep apnea. This is one of the important randomized study, CHAT study, done by Dr. Carol Marcus, she was a legend in, again, another pioneer in the pediatric sleep medicine research, and found that there's a significant improvement after tonsillectomy, significant improvement in quality of life, behavioral and PSG findings, but the main executive function attention score, there was no big difference. But overall, there are many other studies came after this showing that significant improvement in life and quality of life and symptoms after adeno-tonsillectomy. But T&A is not always safe. There are some complications, including respiratory compromise and hemorrhage, and especially some children, like very small children, infants, children with Down syndrome or other craniofacial abnormalities, or children with a very severe OSA like AHI, like more than 20, they are all prone for complications, and we recommend them to observe in the ICU after the T&A, not to send them home on the same day. Okay, how about medical management? I treat actually some mild OSA, not other complications. They are mild, no significant hypoxemia. I treat them medically, actually. I try some medications. So there are 2 medications which we can try in mild sleep apnea. One is intranasal steroids. We use Flonase a lot, right? Flonase. And studies, and there are basic science and translational studies showing that the steroids can control the inflammatory pathways in the local, in the mouth, in the nose and throat, and help them breathe better. And also another medication that I use is montelukast. The studies are showing, and I was part of a study where we collected tonsils and adenoid tissues from the OR, from the ENT surgeon, and we did some studies on inflammatory markers in this specimen, and use steroids and montelukast, and see that, and eventually we found that those tissues shrink after we use this medication. So, and also there are clinical trials showing that use of these medications, actually they about 3 months they get better, they breathe better, their tonsils are not shrink, and I recommend this. I use this actually in mild obstructive sleep apnea, and where they are not, or they have OSA but they are not a candidate for surgery, or they cannot do CPAP, I try these medications. Or if they have a surgery scheduled after 4 months or 5 months, in the meantime I use these medications, and it helps a lot. So some children have persistent or residual sleep apnea. Obesity is one of the risk factors. Some of the obese child with a significant sleep apnea, we actually put them on CPAP right from the beginning, meanwhile awaiting for the ENT appointment. Severe OSA tend to persist, older age, and asthma. As I said, asthma has a very strong association with the sleep apnea. African ethnicity and history of prematurity. These are children with who can have persistent sleep apnea. CPAP. Okay, so what are the indications for CPAP? So small tonsils, adenoids, but they have significant sleep apnea. They're not candidates for surgery. Yes, I think we should try CPAP. Residual sleep apnea, about 25% of children can have residual sleep apnea after TNA. They probably need CPAP. OSA with obesity, OSA in craniofacial abnormalities and neuromuscular disorders probably need CPAP. Okay, and so CPAP helps maintaining the patency of upper airway throughout the respiratory cycle, improve functional residual capacity, and also decrease work of breathing. And prescribing CPAP is not enough. We should work with the children, especially in children. Adults, maybe okay, the respiratory therapist can take care of all those things. But for children, it's very, very important to select the proper interface. This is something actually many people, I saw that underestimate, but selecting a good interface is very, very important in children. And recently we had a child in the PICU a few weeks ago, and we had to try a long time to find the best interface for the child. Switch between like 5 or 6 interfaces and find the correct interface and to go home. The baby to go. That was a 6-month-old baby to go home with. So this is very important. Just prescribing the CPAP is not enough. Go to bedside and see if there is a good mask fitting. If not fitting, change it to another one and find the best mask for this child. Okay. These are some popular masks in pediatric practice: WISP and the Pixie. So it's a big challenge to start CPAP in children. It's very, very difficult, and it takes. And if you just prescribe, deliver the machine and mask at home, doesn't mean anything. They don't use it. Anything put on their face, they don't like it. They're going to pull it away. So we have to work with the child. Sometimes child life. We work with child life to get them used to give them nice stories of magical mask, or this guy is trying to get the best fit for his mask. And it's very difficult. It may take up to many weeks, up to a couple of months for them to get used to the mask. We use mask desensitization. That means don't start at the night time. Give the mask to the child in the daytime, okay, and disconnect from the CPAP machine. Just give the mask, put on the face, and play with around. Make it a very pleasant and positive experience. Work that way, and then slowly start putting at the night. Actually, we do that as called mask desensitization. And positive reinforcement, he get a star. If he use the mask for tonight, he get a star. If he get a 5-star, he can collect stars, and he can get a favorite chocolate. Now we use that actually. It works sometimes, and this is very challenging. It's difficult to get them used to it, especially preschools and early school children. And also CPAP is not without complications. Humidification should be humidified with distilled water and not with beer. Right? This guy was apparently using beer for in the humidifier. So with distilled water, but if you not clean the humidifier properly, every day you have to clean and change the distilled water, they are at risk of fungal infections. And skin breakdown is a very common complication. Sometimes we can use CPAP liners under the mask to prevent the skin breakdown. If there is a skin breakdown, sometimes we use something called mask alternates, or alternating between masks, prescribe 2 different type of masks to alternate between masks to change the pressure point, skin pressure point. And the long-term mid-facial hypoplasia is a complication of CPAP and the mask. So dental procedures, so selected candidates, there is a crowding of the oral cavity and high arch palate. So the dental surgeon can use this maxillary expansion device, and still pediatric studies are in the process of, these studies are still being conducted. So these expand the maxilla and create more space in the nose so they can breathe better. And there's a very few pediatric studies showing that there is some good efficacy and improvement in sleep apnea with these kind of procedures. So adjunct therapies, environmental controls, smoke exposure, very important, control of allergies, weight loss, extremely important. All of our patients with high BMI, we tell them to go for a weight loss program. We refer them to nutrition and weight loss management program, extremely important. Supplemental oxygen is not a treatment for sleep apnea. It's not a treatment. Why? Because oxygen can take care of only oxygenation, can take care of hypoxia. How about hypercapnia? Because most of these patients have hypercapnia and hypoventilation. Oxygen is not going to take care of. But some of our patients are on oxygen because we are not able to get them to surgery. They are not candidate for surgery. And also we cannot do CPAP for them. They are not a candidate for CPAP also. So those children, especially with medically complex patients with multi-system issues and neurologically complicated patients, they are on oxygen. So we can't help it. One point I want to tell you about oxygen. I had an experience in Children's Hospital, DC, in emergency room. A 12-year-old, very obese adolescent came. He had chronic obstructive sleep apnea, big tonsils, and no medical attention for many years. No, he didn't go to anybody for this. And he came with a URI, right, symptoms to the emergency room, and he fell asleep. Now these children, they're going to fall asleep everywhere. When you're talking to them, they're going to fall asleep. Eating, watching TV, they're going to fall asleep everywhere. Those are the children at risk of this complication. So that child was in the ER with some URI symptoms, and he fell asleep in the ER. When he was asleep, his oxygen saturation dropped to 80s and some 70s. So the nurse panicked, and the nurse put 3 liters of oxygen for him. In next 45 minutes, he was in the PICU intubated. So what happened? What happened for the child? What was the problem? So these patients with the chronic obstruction, they breathe on hypoxemic drive. Because all of us, we are breathing because of the hypercapnic drive. Carbon dioxide is a drive to breathe. For this patient with the chronic obstruction, the carbon dioxide is there used to the hypercapnia. Carbon dioxide is no more a drive for breathing. So the drive for breathing means hypoxemia. So the nurse giving 3 liters of oxygen suddenly abolished his hypoxemia. So his drive for breathing is gone. So he was not breathing. He went into complete apnea. He has to be intubated. He was in the PICU. So there's something very, very important you have to remember. Any patients with not just OSA or COPD in adults, any patient with a chronic obstruction, they are living on hypoxemic respiratory drive. So if you give them a lot of oxygen, they're going to go to crash. So very, very important. So positional therapy, you have to, when these patients lie on the back, they have a lot of snoring, lots of symptoms. So you recommend them to lie on the side. So it's not easy to lie on the side, right? You lie on the side, you're going to go back and snore again, awake, again lie on the side. It's a cycle. So there are some bells and pillows available to help to lie on the side. Even a tennis ball, see? So some of my mentors, they told us they used to use this, stitch a pocket on the back of the shirt and put a tennis ball there. So you can, it will help in lie on the side. And there are some nasal devices. It's not well studied in children. Nasal expiratory resistor device to keep the airway open. And some physical therapies to enhance them for nasal breathing. There are some adjunct therapies. It can help, but not a lot studied in children. I think we talked about this. And Down syndrome, a special population, Down syndrome is at risk of sleep apnea because of anatomical factors, and we should definitely screen these children for sleep apnea and treat them if possible. Craniofacial abnormalities with like Pierre Robin syndrome, they have mandibular hypoplasia, crowded midface, and they are at high risk of sleep apnea. Majority of the half to 3/4 of these children will have sleep apnea. Actually, we had a lot of patients like this, and it's very, very difficult to work with them. It's extremely difficult to start CPAP or something for them. And many of them, a few of them will go for surgery actually, surgery in the midface to create some space for them to breathe, but by oromaxillofacial surgical team. And this is Pierre Robin syndrome, and we have consulted sometimes in the neonatal ICU for these kind of babies to see what to do. What we recommend, there's a nationwide research study going on in these babies. Actually, what we recommend is to get a baseline sleep study and then do the palliative procedures. Palliative procedures is like tongue lip adhesion, something like the surgery, and then come back later at first year before the first birthday and then do the actual procedure. So they are very high at risk of sleep apnea. Some mild cases, you can use some appliances, a drinking plate or something like that to help them feed, actually. But some severe cases, some babies with a severe obstruction, unfortunately, they probably will need tracheostomy, and I followed some children with this. And eventually, when they grow, there may be some improvement, and they can go for definitive surgery, and we can decannulate and take the tracheostomy out. I talked about this. The palliative procedure, initial procedure is tongue lip adhesion, and later on do the corrective, actual definitive procedure. So lastly, some recent advances in pediatric sleep medicine research. Now, it's an era of omics. So, and personalized medicine, precision treatment. There's a few research projects going on in terms of using proteomics and genomics to create personalized treatment for children with sleep apnea. So, they sample the blood and do genomics, do microarray to get the genetic background for these children, and also do proteomics, get the proteins, and relate this genomics and proteomics with clinical complications and decide the best personalized treatment for these children. So this is going on, very interesting, which is some advances in pediatric sleep medicine in terms of omics perspective. So there are some, so urinary metabolites can be used in, not in the diagnosis per se, but in terms of prognostication, and also changes in metabolites sometimes are associated with the cognitive dysfunction. So you can identify those children who can have cognitive problems and treat them early and things like that. This is also under research. There are some metabolites you can study in the urine to detect sleep apnea and for prognosis. And lately, there are some new things coming up with artificial intelligence and cloud algorithm based on screening children with using phone pulse oximeter, a pulse oximeter and the phone oximeter, and also cloud-based algorithm to diagnose, screen for these children, and also it helps in the prognosis of these children. So, in conclusion, so sleep apnea is happening. It's a complex disease happening because of upper airway narrowing, increased collapsibility, and systemic inflammation. And there is a lot of phenotypic variations, and this is influenced by genetic, environmental, and disease severity in susceptible individual susceptible factors. And also, it's time to look for precision medicine and personalized treatment for these children to decide what treatment for particular child, particular patient, especially if the new genomic and proteomic research will come out and approve some guidelines. I was also actually part of another project where to develop a non-invasive biomarker panel for sleep apnea. So to swab the throat and get biomarkers and see and predict who can respond better to tonsils and adenoid surgeries. And this is the most important thing I want to tell you all today. Look for them, screen for them, because early identification and management is very, very important to prevent neurocognitive problems. And so screening by primary care provider is highly recommended for these children. So again, do not ignore the snore. Yeah, so if you all, just for kids and adults, if you all see yourself or your family, your friends or children or your patients, anybody is having otherwise unexplained cognitive dysfunction, memory problems, or even fluency of the words, or something sometimes called word constipation, those persistency of these kind of problems, and you don't have any other medical problems like brain or stroke or anything like that, think about your sleep. Think about your patient's sleep. Ask about your patient's sleep. Are they getting adequate sleep? Are they having sleep interruption? Are they having hypoxemia? And also say, and there are many studies showing that if it's treated, if you use CPAP, these things are preventable actually, even reversible in the initial phase. This is extremely important. There's a lot of studies going on, they're still going on. And again, as I said, Very small children and old age people are more prone for these things. So this is one of the important take home I want all of you to understand today. And this is a very important public health problem actually. So thank you for your attention.
Questions? Monica.
It's a great overview you did. Certainly love your slides and the cartoons. A couple of questions. You mentioned pulmonary hypertension. We worry about a kid with upper or lower airway. That's a new thing. As you know, your ex-boss, she's the vice president, she's world-renowned expert on it. And there's a lot of controversy about when do you do an echocardiogram. For instance, some Europeans do echocardiogram on any preemie once they're going home, 36 weeks, or at least once in the first year of life, because there's a residual. Some of it is lung, some of it is the upper airway. So that's number one question. Number two, you did mention at the bottom of your list preemies. In preemies, of course, nowadays we are doing non-invasive ventilation. But if it's the invasive ventilation, our teaching is you always do a bronchoscopy at some point in time, or nasopharyngeal scopy, and to see how the airway collapses during expiration or not. If you care to comment on those things. And certainly you mentioned several times, very important, including this slide. So education, which was your paper. So I think a simple thing like putting a big sign there, or if they're watching the TV, your child is snoring, talk to your primary care doctor. That's so important, I think, from what you alluded to.
Yeah, thank you. So the first question about when to do the echocardiogram. So we have an algorithm, actually still being developed algorithm, how to go with these children with snoring and sleep apnea. So what we do is, if they have severe sleep apnea based on polysomnography, no matter how is the duration of the symptoms, if you have AHI is more than 10, we do send them for echocardiography, at least a baseline echocardiography, so to see if they have pulmonary hypertension. After that, we screen them almost every year for pulmonary hypertension. Small babies, so we don't specifically do anything until they are in your territory, until in the neonatal ICU, we don't do anything especially. So but we screen them I always ask them sleep questionnaire once they come to follow up in the clinic. After they are in the ICU and they come to the clinic, ask for sleep symptoms. And as I mentioned, there is MRI study showing that preemie babies' airways are smaller than compared to other children. So we ask them sleep questions, and if they have questions, especially pauses, snoring probably not in the infancy, they may not snore, but what we have to ask is the pauses, apnea. So if they have, yes, we do send for a sleep study, and the management is very difficult for them. It's very difficult, but we can see if we can do anything by surgical intervention. But doing a CPAP in an infant is extremely difficult. But usually we don't do anything in the neonatal ICU. We do bronchoscopies to look for malacia, actually, airway malacia, but not in the sleep perspective. And other thing is in terms of the screening, yes, that is the phase 2 study from this. That was a phase 1. Phase 2 study. We are actually applied for a grant from the Academy of Sleep Medicine. We are trying to talk to American Academy of Pediatrics about establishing a definitive screening with all the pediatricians. Like, for example, autism screening is mandatory now for everybody, and to make this also a mandatory screening, that's actually in the work as a work in progress.
One other comment, you said you had this kid in the PICU that had apnea, didn't respond, and you showed the polysomnogram very nicely where there was, as you went up gradually on the CPAP, there was no response at all.
Yeah.
So we would recommend BiPAP or nasal intermittent ventilation.
Exactly. So if they require very, very high pressures, they're not going to tolerate that much of airflow. Yeah, so we switched them to BiPAP. That's the indication for actually doing BiPAP.
So I guess for the people going into primary care, for that younger child who is under 4, who has sort of +3, +4 tonsils, kissing tonsils, and a good supportive history of snoring, should that child get a sleep study before they go to ENT, or do they go to ENT for surgery?
Great question. There's actually a big tug of war between ENT, is Dr. Gangur here? No, right? ENT and pediatric pulmonology or pediatric sleep medicine. So they generally do the surgery without a sleep study. But we highly recommend to get a baseline sleep study before, because we need a baseline. Otherwise, we don't know. After the procedure, we need to get another study. If they have continued symptoms, we don't have a baseline. So we, the pediatric pulmonology community, strongly recommend to get a baseline study before the surgery. But ENT people, they don't listen to us. But it's strongly recommended to get a baseline study before the surgery. So they say that, oh yeah, clinically, you don't need a study. Clinically, here, so I say, let's get the surgery done. But I strongly recommend a baseline study.
Okay, and then the second question is related to when they have severe obstruction. The reason they're in the PICU or held overnight after TNA is the same reason that 12-year-old that you were talking about in the emergency room, is that their hypoxic drive is then taken care of because they have the obstruction removed and now they have better oxygen. They may not breathe very well.
Yeah.
So is that why, that's why you're watching them?
Right, exactly. And also they can get post-obstructive pulmonary edema. With the severe OSC and big tonsils, there is a complication post-obstructive pulmonary edema. They can have that, so they need to be watched in the ICU.
Over the years, we've had a lot of children who then have their tonsils out and then they won't breathe for a period of time. So you just have to get them to reorient their oxygen drive. All right. Thank you very much, Dr. Kilaikode. It's a great presentation.
Thank you.